When we see patients in our clinic who have newly diagnosed multiple myeloma and that are transplant eligible, our goals have recently changed. We're going for the deepest response possible. And that is a decision that is made right from the beginning when you choose the regimens that are going to create the best level of response. As of now, the standard of care in the United States has been the induction with a triplet-based combination, mostly in the form of lenalidomide, bortezomib, and dexamethasone, followed by autologous stem cell transplant, and then followed by maintenance study, which we will discuss later. Now, this paradigm is also being challenged because we do have regimens that are producing a deeper level of response. Some of these regimens are being tested in phase 3 clinical trials. But at the recent ASH meeting, we had a number of presentations that show very exciting results. As an example, there's a study that was presented by Dr. Gay from Italy that looked at the combination of carfilzomib, lenalidomide, and dexamethasone, followed by stem cell transplant, followed by more of the same, and then maintenance. And using a threshold of sensitivity of 10 to the minus 5 for MRD, essentially 60% of patients achieve MRD negative status post-transplant. Now, I think this is a remarkable outcome. And if those patients are able to sustain that MRD negative status, what is being defined now also by the international group as sustained MRD negativity, a fraction of those patients will be cured from their multiple myeloma. So when I see new patients now in my clinic, number one, I tell them we're going to go for the best possible response. I do discuss the possibility of myeloma being a curable disease, because if you're able to achieve this very, very deep levels of response and sustain that, then the data in the literature shows that there's a possibility that these patients may not need any more intensive therapy. We spend a lot of time arguing about what's a cure or not. I think it's mostly arguments about definitional items, but in fact, if you can sustain control of the disease such that a person can complete a normal lifespan, in my mind, the disease is cured, and I think we're doing that for a fraction of myeloma patients.
Well, there are many regimens that are available for the pre-transplant treatment. So initial management of multiple myeloma in the transplant-eligible patient is usually with a triplet therapy, very commonly lenalidomide, bortezomib, and dexamethasone. So the immunomodulatory drug lenalidomide, the proteasome bortezomib, and dexamethasone. It's common because the overall response rate is nearly 100%. 3/4 of patients get a very good partial response, and half of patients get a complete response, including patients who are MRD negative. Now, there can be substitutions. The proteasome inhibitor carfilzomib, together with lenalidomide and dexamethasone, has been also studied and gets similar high rates of overall and extent of response. We have now being presented at the American Society of Hematology in the transplant-eligible patients the addition of monoclonal antibodies to those triplets. So, for example, lenalidomide, bortezomib, dexamethasone plus daratumumab. And in clinical trials already is lenalidomide, bortezomib, dexamethasone, and elotuzumab. At this meeting, daratumumab data added to lenalidomide, bortezomib, dex was presented in a very small trial, 14 patients, but it does appear that adding monoclonal antibodies to these active triplets can not necessarily increase the overall response rate because it's already very high, but can increase the extent of response.
We've come a long way with the induction treatments for multiple myeloma, and the good news is we have options now. We have been using a triple combination of treatments for this patient population for a very long time now. And based on data, we have been using VRD or RVD, which is lenalidomide with bortezomib and dexamethasone. And there is a SWOG trial now which has compared this triplet to the doublet. Certainly this trial was done in a transplant-deferred patient population, but nonetheless, the triplets was the better regimen to use. More recently now, we have carfilzomib in this space as well. Carfilzomib in combination with lenalidomide and dexamethasone. Now, most of the data with KRD, or carfilzomib, lenalidomide, dexamethasone, is phase 2 data. There's a little bit of data looking at phase 3 studies, and there is in fact an ECOG study called the Endeavor trial, which is going to compare RVD to KRD. We don't have the data on that, and as of right now, I think given that bortezomib is approved in the upfront setting, VRD is probably the go-to treatment for the transplant-eligible patient as induction treatment. When it comes to KRD, I certainly use KRD mostly in the context of a clinical trial, only because carfilzomib as of right now is not yet approved. Now, the question of which one is better is still an open question. There's been kind of retrospective reviews on data looking at KRD versus RVD, and when you do a retrospective review of historical data, there's always a problem with that. There is a hint of a suggestion that KRD tends to produce better responses, but I think we should wait for the Endeavor trial to see whether or not we can decide which induction regimen is better, whether it's KRD or RVD. Given that we are now routinely using triplets in the treatment of multiple myeloma induction treatment, the obvious next question is, should we now be using 4 drugs? Well, this has been tried before. Several years back now, we did a trial with RVD with Cytoxan, for example. That was not a successful endeavor, given that Cytoxan actually increased toxicity and we saw increased mortality in this patient population. So one can argue and say that Cytoxan is probably not the best partner to combine with RVD. Given that we have monoclonal antibodies now, the next step would be to use triplets in combination with a monoclonal antibody. And at this year's ASH, there was very early data looking at RVD with daratumumab, for example, and earlier at ASCO, we'd seen data with KRD and daratumumab. So I do think quadruplets should be tested in this space. And specifically, if you want to try and get a really good response and a deep response even before going to transplant, because there's enough data to demonstrate that the depth of your response, even pre-transplant, is a prognostic marker in terms of how patients do. So the better the response is even before a transplant, I think would be a good idea. It needs to be tested though, and we want to make sure that we are not getting undue toxicity by adding more and more drugs.